This is chapter 33. This is care of the patients who have vascular problems. Pace yourself with this chapter because it is pretty detailed and it's long. So your priority concepts for this chapter are going to be perfusion again and clotting. The interrelated concept for this chapter is inflammation. Let's start and use our exemplar here with hypertension. Your desired blood pressure for people over 60 is below 150 over 90. For people younger than 60, it should be below 140 over 90. According to the Joint National Committee 8, GNC 8 guidelines, patients whose blood pressures are above these goals should be treated with drug therapy and lifestyle modifications. Hypertension is the most common health problem seen in primary care settings. It can cause stroke, an MI, kidney failure, and now they're saying, this is according to your new book, that for people less than 60 that it should be below 140 over 90, but the recommended guideline is 130 over 80 in all people. These are guidelines, and you have to look at your age and when they should have treatment. Any people who have above these goals, 150 over 90 for older people and 140 over 90 for the people less than 60, they should have treatment if they're over or at this point. But the desired blood pressure guidelines is for a good blood pressure to be 130 over 80 in all people. So this is an interesting concept for you. It's the blood pressure. We all know what the blood pressure is, don't we? Well, let's really look at the blood pressure. What it is the cardiac output, the amount of blood that's pumped out by the heart, and the peripheral vascular resistance. So that cardiac output, remember, is the stroke volume. That's how much is pumped out with one stroke of the heart, or one beat of the heart times the heart rate. So that's your cardiac output. Control of your peripheral vascular resistance, which is the vessel constriction, that's your blood vessels all over your body, the constriction and the dilation. This is maintained by the autonomic nervous system and hormones. Any factor that increases or decreases your peripheral vascular resistance, the heart rate, or the stroke volume will increase or decrease your systemic arterial pressure, which of course is your blood pressure. This dictates the perfusion within the body. So that is what blood pressure is. Now there are, as I said, there are things that influence the blood pressure. The arterial baroreceptor system is one of them. This is what monitors the level of arterial pressure and then counteracts a rise in that arterial pressure through a vagally, Vagally, mediated cardiac slowing, slow the heart rate, but using the vagus nerve. And it will cause vasodilation, which will decrease the sympathetic tone. So that's your arterial baroreceptor system. These are four very important systems that control or influence our blood pressure. Of course, regulation of body fluid volume. If there is a rise in the blood pressure that changes the venous return to the heart, such as excess sodium, that changes that venous return to the heart, increases it, the kidneys will produce a diuretic, which will lead to a fall in pressure. The renin angiotensin aldosterone system, super important. This is a renal thing. Renin in the kidney, it is a hormone. It is converted into angiotensin 2, which causes vasoconstriction and will control the aldosterone release, which causes the kidney to reabsorb the sodium and inhibit fluid loss. So when the blood pressure is high, the renin level would decrease because of the increased renal arterial pressure, and that would inhibit the renin secretion. So this is a very important factor in the blood pressure control. And if you'll look at this, when I tell you about the renin, it's converted to angiotensin 1, and which in turn is converted to angiotensin 2. Well, if you can block that with, guess what? The angiotensin, the blockers that we use, the prils, the ACE inhibitors. That's exactly what they do. They will inhibit this. So that's why we give them to decrease the blood pressure. It will inhibit the release of renin. Then we have vascular autoregulation. This is something that maintains a consistent level of tissue perfusion. So let's talk about essential hypertension. This is the most common type of hypertension. It is not caused by an existing health problem. It is a continuous blood pressure elevation in patients that will cause damage to their vital organs. It causes thickening of the arterioles, and the perfusion will decrease and the body organs will become damaged. And these changes can result in heart attacks, MIs, strokes, brain attacks, PVD, peripheral vascular disease, or kidney failure. So, common risk factors include, now secondary hypertension is caused by another problem or a medical condition. It is caused by a specific disease state or a drug. And it differs from the usual type of high blood pressure, the primary hypertension or the essential hypertension, and it's commonly referred to simply as high blood pressure. Proper treatment of secondary hypertension can often control both the underlying condition and the high blood pressure, and that will reduce the risk of serious complications, of course, which include heart disease, kidney failure, and stroke. So, it's important that you understand, again, we talked about it just before with the renin aldosterone system, the RAAS. This is the kidney. So kidney disease is one of the most common causes of secondary hypertension. It can also occur during pregnancy. Now, there is another type of hypertension that is very, very critical. This is called hypertensive crisis. This is a malignant hypertension. It is a medical emergency. Symptoms uh, include a headache, blurred vision, dyspnea, and uremia, um, which is an accumulation in the blood of substances that are ordinarily eliminated in the urine. The systolic blood pressure may be over 200 and the diastolic may be over 150. If it's not treated promptly, the patient may experience kidney failure, left ventricular heart failure, and they may even have a stroke. So this is important that this is treated quickly. It is a medical emergency. Okay, essential hypertension, the genetic risk is for essential hypertension. Family history, of course. African American ethnicity is a cause of essential hypertension, hyperlipidemia, smoking, being older than 60, and obesity, physical inactivity. Um, People who have um, risks of secondary hypertension include those who have kidney disease, people who have um, um, excessive stress. Um, they may have pheochromocytoma, which can cause is related to the adrenal gland, and Cushing's disease, coarctation of the aorta can cause um, hypertension, and so can brain tumors, encephalitis. We talked about pregnancy earlier, and some drugs, the oral contraceptives and the glucocorticoids, can cause uh, secondary hypertension. But the main cause is kidney disease. So there's a lot of people who have hypertension. It's a worldwide epidemic. There are 85.7 million Americans older than 20 years old have hypertension. Here are some health promotion and maintenance treatments or preventive measures for hypertension. Um, there are evidence-based dietary and exercise practices that can help lower blood pressure. They should achieve some weight reduction through lifestyle changes, including calorie intake changes and increased physical activity. They can use the DASH, DASH diet, which is a diet that's high in fruits, vegetables, and low-fat dairy. Uh, they should enhance the intake of potassium, calcium, magnesium, and fiber. That's what the suggestions are. Also, reduce the intake of dietary sodium to less than 1,500 milligrams of sodium per day. Increase physical activity. Um, this is important because they should have that will help them lower their blood pressure and their weight, and give them this would include aerobic exercise, resistant uh, type training, and static isometric exercise. These are all very good suggestions to prevent or to reduce high blood pressure. Now, we've talked about hypertension and we've discussed it, and we kind of know what it is now, don't we? Um, when you're checking your patients, you always do your assessment, and even within your assessment, you know that you're going to do history. We always, always, always do our history. When you admit a patient, when you talk with a patient, every morning, how you doing? What happened? Has anything changed? Do you have you're getting a history from the patient. So you want to ask about their risk factors, their age, their ethnic origin or race, their family, history of hypertension, their average daily intake of calories, sodium, potassium, alcohol consumption, their exercise habits. All of those are important when you're asking their history. And if you're doing a focal assessment for hypertension, then these are all very important questions to ask. You want to know if they have a past or a present history of kidney disease or coronary vascular disease. Do they have any history of drug use or so now we have looked at our assessment. What other cues are there? Well, we always got to look at our diagnostic assessment. This is really important that you be aware of things that may indicate problems with that can cause secondary hypertension. The BUN might be elevated. The creatinine might be elevated. Their red blood cells, they may have some red blood cells in the urine. All of that might indicate kidney disease. If you were checking for their blood cortico, so now we have recognized, we know what causes our high blood pressure. We have looked at our assessment. We have looked at our lab values and our diagnostic testing. So now what are we going to do? What have we got to teach this patient? What are our How do we analyze these cues? These are all cues that we've just looked at. How do we analyze that and then prioritize what we need to do? Well, we got to teach these people. The main thing is teaching. Due to their management of their hypertension, they need very detailed teaching. And one of those teachings is the potential for their decreased adherence due to side effects of drug therapy and because they need to change their lifestyle, be it stress, be it exercise, eating differently, lose weight. But the main thing here is if they do that and they start feeling better, they may stop taking their medications. And they cannot do that without the physician being aware of it or reassessing them because that sometimes they don't have symptoms and they think that their blood pressure is doing fine, but it's really not. So we really need to make sure they well understand their plan of care, their plan of treatment, and that's where you come in. Teaching, teaching, teaching. That is your job. Okay? Let's move on. Well, I just said that, didn't I? Health teaching and promoting adherence to the plan of care. That is what your solutions are. This is what you're going to do. So there you go. Okay, now we've done all of our stuff, but now I'm going to reiterate some things here, and I know very well that I'm doing that, but this is what we do when they go home. So I want you to really get this. There's very important stuff on this slide. Home care management includes the teaching that we've done. We want to make sure that we have them teach us back what we've told them. Their lifestyle change. So let's evaluate what we've just done. You're going to evaluate your patients related to your teachings. They are going to verbalize to you the understanding of that plan of care, including their drug therapy and any necessary lifestyle changes. They're going to verbalize that to you and give you rationales as to why they need to do that. They need to know to report any adverse drug effects, such as coughing, which might be related to the ACE inhibitors, dizziness, or sexual dysfunction, which might be attributed to the beta blockers, and they should do all that and call their primary health care provider immediately. if they have these adverse drug effects, because then they can change them and they don't have to come off of their of a medication and be off of it for an unreasonable amount of time. Consistently adhere to the plan of care, including regular follow-up with their primary health care provider. So you're going to teach the patient to eat foods high in potassium if they're on a diuretic, and to have a follow-up laboratory test because you want to monitor their electrolyte levels. And now next we're going to talk about the drugs. We're going to talk about what drugs are out there that they're going to be giving to your patients with hypertension. So we're talking about drugs for hypertension. Diuretics are usually the first type of drug that may be given to manage hypertension. The thiazides, hydrochlorothiazide, that's the main type of diuretic that's used to treat hypertension. It does treat by decreasing the fluid volume, and it will uh, that will decrease the sodium in fluid content, which will decrease the blood pressure. Vasodilators such as nitroglycerin are also used with patients who have hypertension. Usually it's a patch or some sort of a pill, and you have to be careful and caution them that right after they take it, they need to be careful when they sit up or get up to make sure they stabilize before they fall. Beta blockers helps to reduce the heart rate, which will of course should decrease the blood pressure, and that would be your Inderal, atenolol, those sorts of drugs. Also, angiotensin converting enzyme, the ACE inhibitors, will widen the blood vessels and aids the blood flow and reduces the blood pressure. Those are your prils. Captopril, lisinopril, you will see those given quite frequently. Angiotensin 2 receptor blockers will help relax the blood vessels also, and that's your sartans or the losartan, those drugs. So if they can't take an angiotensin 1 inhibitor, if they cannot take an angiotensin converting enzyme, then because it makes them cough, then they can probably take an angiotensin 2 receptor blocker because they work the same, but they don't cause the same sorts of side effects. Calcium channel blockers can also reduce the amount of calcium. Remember the calcium channels, and that will reduce the heart rate and help control their blood pressure. And that's your penes, your amlodipine, felodipine, those sorts of drugs. And alpha blockers. The muscles of the arteries and veins are relaxed, and that reduces the blood pressure. That's your SINs, the doxazosin and prazosin. These drugs are also used. They're alpha blockers. So, what if you have a patient who comes in and they're having a hypertensive crisis? Now, I worked in medical ICU, so I've seen many people come in hypertensive crisis. They will have a severe headache. The blood pressure is extremely high. Dizziness, blurred vision, shortness of breath. They may have a nosebleed and be very, very anxious because all of this makes them feel like crap, and they're hurting, and they don't know. They just almost can't see what or even hear what you're telling them. So you're going to place them in a semi-Fowler position. Don't lay them down, but a semi-Fowler position. Put a little oxygen on them. And probably what you're going to do when ordered, you would give them an IV beta blocker or nicardipine or some other kind of drug that they may, usually it would be IV drug, and get that blood pressure down. Once they're stable, they would switch to an oral antihypertensive. But to begin with, they probably are going to give them IV medication to get their blood pressure down. Nicardipine is a calcium channel blocker. Um, and a beta blocker might be low pressor, something like that. It will be prescribed, but be aware of that. And then they might switch them over to oral antihypertensives. You want to monitor their blood pressure every 5 to 15 minutes until their the diastolic is below 90 and not below 75. Then you're going to monitor um, their blood pressure every 30 minutes to make sure that their blood pressure is not lowered too quickly, because that can cause brain swelling, or it can cause them to have neurological problems. So you're going to watch for seizures, numbness, weakness, tingling of extremities, any dysrhythmias or chest pains, because those are the targets. Those are target organ that you're going to be watching for. That's where the damage would be seen first. So they could have a stroke, they could have um, um, symptoms of a stroke, or they could have heart problems, and of course renal problems. So you want to make sure that you are monitoring these patients very carefully. Now, you may see them in the ER, they may develop this on the floor, but these are generally treated in ICU. Okay, now let's switch gears here and talk about our vessels. Let's talk about arterial sclerosis and atherosclerosis. Arterial sclerosis is a thickening or hardening of the arterial wall, and this is quite often associated with aging. Arterio is associated with aging. Our body grows older, and so does our vessels. Atherosclerosis, however, is formation of plaque, or buildup of plaque within an arterial wall. And this is the leading risk factor for cardiovascular disease. So let's talk about the pathophysiology of atherosclerosis, which, as we said, it's the formation of plaque within the arterial wall. The leading risk factor, again, for cardiac or cardiovascular disease. It affects the larger arteries, such as the coronary arteries, the aorta, or the carotid or vertebral arteries, the renal, the iliac, the femoral arteries. It can occur from blood vessel damage that causes inflammation, and that could be in response to cell injury. The vessel can become inflamed, and a fatty streak will appear on the intima, or the inner part of the surface of the artery. And this will cause a fibrous plaque formation, thus causing partial or complete blockage of the blood vessel. And these plaques can become calcified. They can be hemorrhagic, ulcerated, or thrombosed. It affects all layers of the vessel when it's thrombosed. The rate of progression is influenced by genetic factors such as hyperlipidemia, chronic diseases such as diabetes, and their lifestyle habits such as smoking, eating, and their exercise. So that's the pathophysiology. So this is what we're going to look for. We're going to monitor their blood pressure. You have to palpate pulses in all major sites of the body. Assess for prolonged, over 3 seconds, capillary refill. And you would also assess for bruits. Be careful when you're assessing for bruits, especially in the carotid. You only assess one side at a time. And if there's a palpation that you see, then leave it be, okay? Especially in the abdomen. So never, if you see a palpation or heart palpation in the abdomen, um, you do not um, you do not press on it. It could be an aneurysm. So our picture here shows you what a normal artery is. The blood's running through just fine, and then you start getting a buildup of the plaque, which is a fatty buildup, and then you have some spots here that are entirely blocked with that fat or the plaque. So your assessment is super important here. This is noticing. You're going to notice these things. And when you note them, you're going to think, because you're doing a focal assessment here, you would want to assess the blood pressure in both arms. And again, palpate the carotid arteries separately. Listen for a bruit. Look at their capillary refill. And in the lab work, you want to absolutely um, look at their HDL, their LDL, their lipids, the cholesterol, of course, both HDL and LDL, and note that they would be at risk if they're elevated. So that's one thing. Elevated triglycerides is a marker for lipoproteins, and that can also suggest metabolic syndrome, which would increase the patient to be at risk for coronary artery disease. So we have to look at all those things. So, okay, what do we do about it? We're going to, we noticed all this stuff. Now what do? We noticed it. Well, now we got to take action. So we know that teaching is part of this. Low risk people should have their cholesterol levels evaluated about every 4 to 6 years, and those who have a risk or they're older than 40 should probably have it every year. Interventions for patients with atherosclerosis or those at high risk for disease focus on their lifestyle changes. This is very important that at this point they should be changing their lifestyle and preventing any further uh, buildup of the fat. So you're going to teach the patient about the need to make daily changes by avoiding or minimizing their risk factors. Those are the factors that can be changed or controlled. And that would, of course, include smoking, weight management, and exercise. So now let's talk about drug therapy for our high cholesterol. Um, the statins, these are a class of lipid-lowering medications. They have been found to reduce cardiovascular disease and mortality in those who are at risk for cardiovascular disease. The most common side effects include headache, difficulty sleeping, flushing of the skin, and muscle aches or tenderness in the muscles, drowsiness, and dizziness. The ezetimibe is often used along with a cholesterol-lowering diet or a low-fat diet and exercise, and it can be used alone or with other drugs such as statins or fibrates. This drug may increase the risk of liver damage, so they would do liver function studies occasionally. And it can also cause muscle damage when it's taken with a statin. So you would tell the doctor or tell your patient to notify the doctor if they had any of those symptoms. These PCSK9 inhibitors, trade name is Nexletol. These are especially beneficial in the treatment of familial hypercholesteremic patients who are intolerant to statins. And some side effects would include anaphylaxis, angioedema, rash, or urticaria. So let's talk about uh, peripheral arterial disease now. The pathophysiology is related to peripheral vascular disease due to systemic atherosclerosis. It's a narrowing of the arteries, which results in a reduced blood flow to the head, the arms, the stomach, and legs. It usually affects the arteries in the legs, and this will cause leg pain when they're walking. So, this includes disorders which change that natural flow of blood through the arteries and veins of the peripheral circulation, and it will cause decreased perfusion to all of the body tissues. This image here shows you the vessels and where um, all the places where if there is a blockage where you can have symptoms. Um, the narrowing of the arteries will cause reduced blood flow, and it will cause them to have some pain in those areas. Also, it will like when walking, they will get very tired when they're walking, and it can cause claudication, which is leg pain. It's very common. There's more than 3 million cases per year in the United States, and it usually will require some imaging or okay, so what are our cues? Well, in this case, remember this is peripheral arterial disease, which is associated with arterial disease. It's not venous disease. There is a Fontaine, Fontaine, classification. Stage 1, they do not have any symptoms. There's no symptoms at all. Stage 2 is intermittent. This is stage 2A. Intermittent claudication. They can walk 200 meters of walk for 200 meters before they have any pain. Stage 2B is when they have intermittent claudication or pain in the legs when they walk less than 200 meters. Stage 3, they have pain at rest without walking. Stage 4, it's so bad that they start losing perfusion to the area, and they become necrotic and can develop gangrene. So some of the cues that you may see, and when you're looking at your patient, look at their toes and look at the hair on their legs. In that area, you may see hair loss. It may be very dry. The skin may be dry and scaly, very pale. This skin would be very pale, or it might be mottled looking, and their toenails can get thick. If it's severe arterial disease, the extremities become gray or blue or darkened, and then if you raise their extremity up, then it gets really pale. There's no color at all to it. And if it's laying down, it may have a dependent red color, rubor. And of course, they can get muscular atrophy for lack of circulation to that muscle. So the primary treatment options are lifestyle changes and then medications, or they can even have surgical procedures done. So what are you going to do? What is your assessment going to comprise of? Well, you're going to assess the blood flow in the peripheral arteries, and you're going to contrast that. You're going to use contrast to help visualize blood flow through the arteries. Sometimes they'll use a Doppler probe in segmental blood pressure measurements of the lower extremities at the thigh, calf and ankle. That would be your segmental readings. The ankle brachial index, the ABI, compares ankle pressure with the brachial pressure, and that's derived by dividing the ankle blood pressure by the brachial blood pressure. And when you divide it, an ABI of less than 0.90 in either leg is diagnostic of PAD. And you will see that done in offices, especially in the offices where they neurovascular offices, and in places in clinics, they will check for that. uh, Exercise tolerance testing, they will start walking them on the treadmill again after they have resolved their claudication problems, and patients without intermittent claudication will be given an exercise prescription with cardiovascular disease. For patients with cardiovascular disease, they would monitor their exercise, and it would be guided by their tolerance test using the heart rate and the oxygen uptake. So there are several testings that they can do to check for. So, what are you going to do? You've got all your information here. You've assessed your patient. You've got your readings. So now what do? You're going to take action. There are non-surgical interventions, which would include exercise and positioning. You can promote or improve arterial blood flow to the affected leg through the buildup of collateral circulation, which will provide blood to the affected area through smaller vessels, and that can compensate for that occluded vessel. So that's one thing you want to do. You can positioning, of course, promotes circulation for patients with swelling in their legs. You want to teach them to avoid raising their legs above their heart level because extreme elevation slows arterial blood flow to the feet. Patients with swelling may sleep with an affected leg hanging off the bed or sit upright in a chair for comfort. You're going to promote vasodilation by you want to provide warmth to the affected extremity and prevent long exposures of to cold. You want to encourage the patient to maintain a warm environment and wear socks or insulated shoes. You want to caution them to avoid the application of direct heat to the limb with heating pads or hot water because their sensitivity would be decreased in the affected leg and they can burn themselves. Encourage patients to prevent exposure of the affected limb, of course, to the cold, which will cause vasoconstriction. You want to absolutely emphasize the complete abstinence from smoking or chewing tobacco because that absolutely causes vasoconstriction. Drug therapy includes antiplatelet agents such as aspirin or clopidogrel. This can help reduce their risk of MI, stroke, and vascular death. Non-invasive procedures, no, invasive, non-surgical procedures. These include percutaneous vascular intervention, where they go in to dilate one or more of the arteries, and you're going to really observe for bleeding at the puncture site. Atherectomy improves the blood flow to ischemic legs. In people with PAD, it's where they scrape the plaque from the inside of the artery. And then when they do that, most patients will get anticoagulant therapy such as heparin or clopidogrel before and during the procedure. An antiplatelet drug may also be prescribed after the procedure to prevent arterial clotting. You're going to assess that tissue perfusion to the affected extremities, including distal circulation, sensation, and motion. You want to palpate all pulses in both legs and compare the strength bilaterally. The most sensitive indicator is the posterior tibial pulse. Presence of pain, pallor, paresthesis, pulselessness, paralysis, or coolness to the leg is indicative of of clotting, of reclotting. So you want to note early signs. Ulcer formation can also occur with decreased blood flow, and these arterial ulcers are very, very painful, and they can develop on the toes, between the toes, or on the upper aspect of the foot. It would be small and round and hollow in appearance with well-defined borders. And of course, the ankle brachial index, you would be doing that. You would instruct them, you would tell them about um, falling. You would give them foot care instructions. They need to quit smoking and maintain a heart healthy diet, and exercise after they have been given the okay to do that by their physician, and avoid exposure to cold and constrictive clothing. You're going to assess their home environment for safety hazards, especially related to falls. Now, sometimes they will need to have a bypass, aortoiliac and aortofemoral bypass. This is a surgery. This is a major surgery. This includes a midline incision into the abdominal cavity and additional incisions to each groin. It is done to improve blood flow in the lower part of the body. Atherosclerosis is the major cause of poor blood flow. It causes the blood vessels to become very narrow and blocked. In a bypass, tubes, which are called grafts, are placed near a piece of the blocked or narrowed vessel. The blood can move through the graft around the blockage. Problems are rare, but they do have risk. They can bleed, they can have problems from anesthesia, they can have infection, blood clots, or injury to other structures. And if they're smokers, of course, there's that risk that raises the risk of problems if they drink and if they have diabetes or obesity. So you're going to, of course, encourage deep breathing, regular post-operative care that you've already been taught. You're going to monitor for graft occlusion. This would become an emergency situation. And how are you going to do that? You check their pulses and check for pain. You're going to monitor for compartment syndrome. You're going to assess for infection. Compartment syndrome is increased pressure in a muscle compartment or a group of muscles that can cause muscle and nerve damage along with pain. It can be life-threatening if it is not treated, so you want to make sure you monitor for any swelling or anything that can contribute to pain, unexpected pain. Now, in an axiofemoral bypass, they're going to repair a blockage that's located within the main artery, and it will send blood flow to the legs from the heart. This involves adding an artificial artery. The new artery is connected to the arteries of the collarbone and groin to allow proper uninhibited blood flow to the legs. So it's just in a different place, an axiofemoral bypass. So let's look at acute peripheral arterial occlusion. Now this is an acute state. This didn't just build up. It is an acute happening. The pathophysiology is that it's caused by an embolus. So at that point, they can be the peripheral arteries can be acutely occluded by a thrombus, an embolus, aortic dissection, acute compartment syndrome, rupture and thrombus of an arteriosclerotic plaque. The embolus can come from the heart or the thoracic or abdominal aorta, and it can cause acute occlusion, can lead to a limb necrosis or loss of a limb, or a life-threatening ischemia. So they're going to have severe pain below the level of the occlusion. I would ask you to know this. These are the 6 P's of arterial insufficiency, and that would be pain, severe pain, cold pallor, skin's going to be very, very pale. It'll be white. There will be no circulation. There will be no pulse. There will be no feeling. They'll have paresthesia. They will have paralysis of that area. They will also have this polar sensation, this poikilothermia, which is coolness. It will be very cold. This occlusion can be roughly localized to the arterial bifurcation that's just distal to the last palpable pulse. If you feel the pulse, then it would be distal to the last pulse you could feel. This can be very, very painful, like I said. So know these, okay? Thanks. So what do we got to do? We see this, we got to do something fast. Prompt treatment is important to prevent permanent damage or the loss, even the loss of that extremity. I have seen them lose the leg when this has happened before, that they could not get the circulation back and they amputated. You would promote vasodilation by providing warmth to that affected extremity and prevent long periods of exposure to cold. Remember, acute peripheral occlusion is characterized by severe pain, that cold sensation, paresthesia, pallor, and pulselessness in the affected extremity. So the treatment would be an embolectomy, thrombolysis. They may give them thrombolytic drugs, or they might do bypass surgery. Despite treatment, about 20 to 30% of patients with acute arterial occlusion requires limb amputation. And of course, we're always going to monitor for compartment syndrome. Now let's talk about aneurysms. These are aneurysms of central arteries. The pathophysiology overview is that it is a permanent localized dilatation of the artery, or this enlarges that artery to twice its normal diameter. It's an abnormal bulge or ballooning in the wall of a blood vessel. And the aneurysm can burst or rupture, causing internal bleeding, which can lead to death. They're very big vessels, and if it bursts, you can bleed out very, very quickly. If the bulging stretches the artery too far, this can cause the vessel to burst. So an aneurysm that bleeds into the brain can lead to a stroke, and of course it can lead to death. They don't usually cause symptoms, so you might not know you have an aneurysm, even if it's large. They can develop in several parts of the body, including the aorta. That's the major blood vessel carrying blood from your heart to the vital organs, and that is called an aortic aneurysm. The section of the aorta that passes through your abdomen is called abdominal aortic aneurysm. The section of the aorta that passes through your chest is called a thoracic aortic aneurysm. And of course, you have your blood supplies, blood vessels that supply the blood to your brain. That would be a brain aneurysm. And blood vessels in other parts of the body, such as your legs, groin, or neck, would be peripheral aneurysms. And I have given you descriptions here of what kind of aneurysms can form. The fusiform or saccular type aneurysm, it depends on their shape. They can be like a sac or fusiform. They can be a false aneurysm, that's called a pseudoaneurysm, and it involves only the outer layer of the artery. It's a true aneurysm. It has all three layers of the arterial wall. That includes the intima, the media, and the adventitia. If it's dissecting, this occurs when the layers of the wall of the artery separate. They separate or they're torn loose, and that allows the blood to flow between those layers, and that's why it's called dissecting, and it causes them to separate further. And then when the arterial wall separates, the blood cannot flow freely and it may burst. So a dissecting aneurysm is not a good thing. No aneurysm is a good thing, but this is particularly bad. A dissecting aneurysm needs to be treated immediately. So this is just a visual look at the common anatomic sites of arterial aneurysms and the types that we just talked about. You can visualize what they look like. The saccular looks like a little sac. The fusiform is kind of both sides. The dissection is involving separation, where it's going to burst because it's separated, and this makes it even weaker. And this is a false aneurysm, and that is it's where a little blood vessel blows up out there beside the vein or artery. So, what cues do you need to know about? Well, sometimes, like I said, they're asymptomatic, and if they have a problem, it can happen suddenly. A triple A, aortic aneurysm, abdominal aortic aneurysm, they would have a gnawing sort of pain in their stomach, in the abdomen, in the flank, or they might have back pain. It would be tearing type. They would feel like somebody's ripping their back open. They might have a pulsation in the upper abdomen, which you would not touch. You don't want to cause it to burst. It might be detectable if it's at least 5 centimeters in diameter. If they have a sudden severe pain in their back or lower abdomen that radiates down to the groin and buttocks and their legs, this is a critical illness. This is a critical time. They're at risk for hypovolemic shock, which is caused by bleeding out into the abdomen. They are classified depending on where they occur. The type A occurs in the ascending aorta, which is part of the aorta that starts from the lower left chamber of the heart and extends to the bend of the aorta, the aortic arch. That's type A. Type B occurs in the descending aorta, which is in the part of the aorta that starts after the aortic arch and ends in the abdomen. That's just a little extra there to tell you a little bit more about it. Now, if they have a TAA, your cues are going to be back pain. This is caused by degeneration of the aneurysm that occurs in the thoracic aorta. This is called a TAA. They're often found during routine medical tests, such as a chest x-ray or a CT scan or an ultrasound of the heart. Sometimes that's ordered for even a different reason altogether. Thoracic aortic aneurysms are less common than aneurysms that form in the abdominal aorta. An aneurysm can also occur, of course, in the upper and lower parts of the aorta. These are called the thoracoabdominal aneurysms. As a thoracic aortic aneurysm grows, some people may notice that they have some tenderness or pain in the chest or back pain. They may develop hoarseness, shortness of breath, difficulty swallowing, and they may have a mass just above the suprasternal notch, and they may even develop a cough. So, if we have a problem here with your aneurysm, we know that we need to treat it. And if they find it, they need to treat it. So, non-surgical management all of this depends on whether their symptoms and how they found it and what the size is. Beta blockers are used to lower the blood pressure by slowing the heart rate. And there is a condition called Marfan syndrome that is notorious for people having aortic problems, and sometimes they widen, their aorta widens, and so they give them beta blockers to reduce how fast that aorta widens. Examples would include Lopressor or Tenormin, those drugs. They might also give angiotensin II receptor blockers. They may describe this or prescribe this if if the beta blockers aren't enough to control the blood pressure, or if they cannot take beta blockers. And they're also recommended for people who have Marfan syndrome, even if they don't have high blood pressure, to reduce how fast the aorta widens. This would include your valsartan or Benicar. And of course, statins can be given to help lower the cholesterol and blockage in the arteries and reduce the risk of aneurysm complications. And that might be Lipitor or Lovastatin, Zocor or Flolipid. If you smoke, or if the patient smokes or chews tobacco, it's important that they quit. Using tobacco can worsen aneurysms. So those are all non-surgical managements of aneurysms, and especially if they are not symptomatic with it and the size is not too big. Surgery is generally recommended for a thoracic aortic aneurysm when they're about 5 to 6 centimeters or larger. If they have Marfan syndrome or another connective tissue disease or an aortic valve or a family history of aortic dissection, then the doctor may recommend surgery for smaller aneurysms. Most people with a thoracic aortic aneurysm will have open chest surgery, but if it's a smaller, or if they're a candidate for endovascular surgery, it's a little less invasive. So it just depends on what their condition or their need is. The type of surgery you have also depends on the location of their thoracic aortic aneurysm. So when you have aneurysms of the peripheral arteries, about 70% of peripheral artery aneurysms are popliteal. They're called popliteal aneurysms. 20% are iliofemoral, and Aneurysms at these locations frequently accompany abdominal aortic aneurysms. About 50% are bilateral. Common causes of peripheral arterial aneurysms include atherosclerosis, popliteal artery entrapment, and septic emboli. That causes myocardic aneurysms. Peripheral arterial aneurysms are usually asymptomatic when they're found. Thrombosis or embolism, or rarely they can rupture, causes the extremities to be very painful, cold, and numb and pulseless. Remember our P's. So the risk of rupture is fairly low, about less than 5% for popliteal and 1 to 14% for iliofemoral. For leg artery aneurysms, surgery repair can be elective. It's indicated when the arteries are twice normal size or when the patient is symptomatic. Whenever or however the surgical repair is always indicated for all arm artery aneurysms because that can cause serious complications. They can have a thromboembolism from that. They're a greater risk when it's in the arm. The affected segment of artery is excised and replaced with a graft, and the limb salvage rate after surgical repair is about 90 to 98% for asymptomatic patients and about 70 to 80% for symptomatic patients. So after your surgery, you're going to be sure that you're going to report any sudden development of pain or extremity discoloration. You're going to check your pulses. Sometimes they'll have even a stent or a graft with a stent in it for repairing it. So do your usual assessment for arterial problems. Okay, aortic dissection. We've talked about this some, but we're going to refer to this again because this is a very lethal problem. This is a tear. It tears in the inner layer of the aorta. That is the biggest vessel you got. This may cause severe chest pain and upper back pain. It is an emergency situation and it can mimic other heart diseases. Chest pain and pain in the upper back are the most common symptoms of this condition. There's typically severe pain coupled with a feeling that something is sharp and tearing in the chest. Unlike in the case of a heart attack, the pain usually begins suddenly when the dissection starts to occur and seems to move around. Emergency surgery before the aorta ruptures gives a person a good chance of surviving and recovering. But once it's ruptured, the chances of survival decrease exponentially. It's highly lethal and it's an emergent situation. Most people do not survive this if it ruptures. So our cues would be for aortic aneurysm, a rupture or dissecting, would be a sharp, tearing, ripping, stabbing pain that moves from the point of origin. Diaphoresis, nausea, vomiting, faintness, pallor, all of those things that go along with shock. You will have no peripheral pulses, or they will be greatly decreased. When it ruptures, you won't have any. And if you listen to the heart, you would hear aortic regurgitation, a murmur of aortic regurgitation. So, this is a critical patient. They need two large bore IV catheters. This is when they start having the pain and you recognize that this is a problem. If they're dissecting, you have time. So you would insert two large bore IV catheters, start normal saline, 9%, sodium chloride, and any medications that they may need to give to decrease the blood pressure. They would have an indwelling catheter, and then the treatment would depend on where it's dissecting and how much it has dissected. So this is treated as an emergency situation. Hopefully this will be they can get to the hospital and they can get to the ER and they can get diagnosed before it ruptures. This is dissection at this point, so it's not ruptured yet, but it could easily rupture, and they're going to have symptoms already with this when it's dissecting. Okay, now hopefully we've saved our patient and we've got them back home, and now we're going to look at peripheral venous disease. This is a term describing damage or defects or blockage in the veins that carry the blood from the hands and the feet to the heart. Peripheral venous disease can occur almost anywhere in the body, but it's mostly seen in the arms and legs. The most common cause of peripheral venous disease is a blood clot that blocks a vein. It is sometimes it's called chronic peripheral venous insufficiency, and that should not be confused with post-thrombotic syndrome, in which the deep veins have been damaged by previous deep vein thrombosis. This is different from that. Sometimes it's caused by defective valves in your vessels. They don't open and close the way they should. The skeletal muscles don't contract well enough to help the blood pump in the veins, because you know that is done by the contraction of muscles. What you may see are varicose veins, leg edema, skin changes, itching, cramping, diabetic ulcers, heaviness or tiredness, and open skin sores. Now, peripheral venous disease occurs when the veins that carry that oxygen poor blood back to the heart from the extremities, and they become damaged or blocked. Although this condition can occur anywhere, like I said, it usually occurs in the arms and the legs. They vary widely in the severity. Mild cases may not require any treatment, and they may just use exercise, or bandaging the affected area may be recommended. In other cases, surgical intervention may be required to help prevent serious complications such as pulmonary embolism. The most common types of peripheral venous disease include the chronic venous insufficiency, and we talked about that just a second ago. This is where the walls and the valves in the veins are not working effectively, and it makes it difficult for blood to return to the heart. And those varicose veins that we talked about, those are those big old gnarled looking enlarged veins that usually occur in the legs, although sometimes you can see them result in bleeding and blood clots. Deep vein thrombosis, this is where a blood clot that typically forms in the deep veins of the legs, and the serious complications can occur if the clot breaks loose and travels through the circulatory system. Now, there's this thing called the etiology. We people who have peripheral venous disease are prone to having a embolus, um, have this Virchow's triad, and this is blood flow stasis, endothelial injury, and hypercoagulability. So the three factors of Virchow's triad include intravascular vessel wall damage, stasis of flow, it's just not moving, and the presence of a hypercoagulable state. That is what you will see in somebody who is prone to have a pulmonary or a uh, thrombosis, a deep vein clot. Okay, short slide here. The largest number of deaths occur in older adults. Half will have long-term complications if they survive it, and 1/3 will have recurrence within 10 years. Okay, peripheral venous disease. We know we are looking at that, so let's do a history. Let's find out what our patient's history is. You always ask this on their history. Have you ever had a blood clot? Uh, So if they've had a history of VTE, that's going to cue you that, okay, we need to think about this. We need to prevent further problems. You need to know their risk factors. You need to know their prediction score. And the prediction score is the best available model for other assessments that we can get cues from are from the studies that they order. They may have ultrasound, special imaging techniques such as the Doppler ultrasound that can evaluate the blood flow. They may do some angiography where they do uh, inject dye into the blood vessels to see the flow of the blood. And then they can also do MRI. That's a computerized tomography, so that they can look at the blood flow. And they may also do some blood testing. The D dimer would, an elevated D dimer would indicate a hypercoagulable state. So that's a important lab test. So when you're recognizing the cues, you're going to then interpret them. Okay, now we have recognized our cues, and they're on non-surgical management, and we know that that includes heparin and warfarin therapy. Um, this is an anticoagulant overlap because heparin and warfarin work differently. The warfarin or Coumadin works in the liver to inhibit the synthesis of the vitamin K clotting factors. It takes about 3 or 4 days before it becomes therapeutic. So therapeutic levels of warfarin must be monitored, and this is monitored by the INR at frequent intervals. Patient receiving warfarin, the INR should be between 1.5 to 2.0 to prevent further DVT or minimize the risk for stroke or hemorrhaging. Patients with additional cardiovascular or PE issues, the INR would be up to 3.5 to 4.0. A critical value most of the time is greater than 5.0. Notify your provider at that point. Obtain INR baseline before the administration of medication. They start with a low dose and gradually titrate it up according to the INR until they reach the therapeutic dose. So you're going to assess for bleeding. Vitamin K is the antidote for warfarin, and it's used if they have a lot of bleeding. If they're on warfarin, You teach the patients to avoid vitamin K foods, especially the dark green leafy vegetables. This will interfere with the medication um, effectiveness. Now, that just means that they have to know their dose is, if they eat a lot of vegetarians or whatever, they would have to be careful, but their dosage would be related to their usual intake of their dark leafy greens. So you wouldn't just throw them, not let them. You're not going to see surgical management very often unless it's something that's really um, that they're not responding to medical treatment. Sometimes, sometimes they will do surgery and they will have to remove that clot. Um, if it's massive occlusion that does not respond to medical treatment and it's recent, if it's 1 to 2 days onset, they might go in and remove it, especially if it's huge. Um, it's They might put in a inferior vena cava filtration, which is meant to trap the emboli in the inferior vena cava before it would go into the lungs. This is indicated for patients with recurrent DVT or PE that does not respond to medical management, or they don't tolerate the anticoagulant medicines. So that might be done, and after surgery, your primary focus would be to inspect the groin insertion site for bleeding or signs and symptoms of infection. Home care and care coordination is going to be teaching. They need to know how to take care of themselves. If they go home on medication, they need to know the side effects and how to take care of themselves with their lifestyle changes. The self-management education included would be for taking anticoagulants, risk of bleeding, not using a razor, being careful with foods, and making sure that they get enough exercise, and no smoking. And the evaluation would be on reflecting how they can change their lifestyles if to counteract any further problems with the peripheral venous disease. In venous insufficiency, this is a result of prolonged venous hypertension that will stretch the veins, and it will damage the valves in the veins, and it leads to a backup of blood and further venous hypertension. So this causes edema and decreased perfusion. And what you're going to see is venous stasis ulcers, swelling, edema. The veins do not function properly when a thrombosis occurs, or when the veins or the valves are impaired. So venous hypertension can occur in people who sit or stand in one position for long periods, teachers, office personnel. Obesity can lead to distended veins and damaging the valves. Thrombus formation, of course, can contribute to valve destruction. Patients who've had thrombophlebitis can develop chronic venous insufficiency. Their venous leg ulcers are a major cause of pain, death, and healthcare costs. This can result in edema in both legs. They may get this reddish brown discoloration along their ankles, and it can extend up to the calf. I bet you've seen this. And the stasis ulcers results from the edema or a minor injury to the limb that won't heal. It usually occurs over the malleus, and it's more often media in the middle rather than lateral. They have irregular borders, and they're chronic and they're difficult to heal. You can live with them, but recurrence is very common, and there is a risk for um, um, loss of limbs if it's not controlled. If they have to have surgery, that would be for the more severe types. They might do tie off varicose veins, or they might do a vein bypass, which is where they would take a healthy vein and transplant it from somewhere else in the body. So let's talk about our interventions. We're going to focus on decreasing the edema and promoting the venous return. And like I said, it's usually non-surgical unless they need to go in there and on the ulcers, they may need to debride it to help it heal. So what you want to happen is the healing of the ulcer and prevent further stasis and other ulcers from forming. The dietitian can suggest zinc and vitamin A and C, high protein foods. They should promote wound healing, a sufficient calorie intake. You're going to explain to them the purpose of compression stockings, and please make sure they choose the correct size, and to tell them not to roll them down or report it if they become too tight or too uncomfortable. That can cause constriction and be like a tourniquet. So you want to make sure that they have the correct size. You're going to teach them to elevate their legs at least 20 minutes, 4 to 5 times a day, and to elevate the legs above the level of the heart if they're in the bed. Venous or surgery for chronic venous insufficiency is not always performed because it's not always successful, but like I said, it can be done to do a bypass or to do a graft from another vessel. Let's talk just a little bit more about the varicose veins. These are distended, protruding veins that appear darkened and tortuous. They can occur in anybody. The treatment includes the 3 E's: the elastic compression hose, exercise, and elevation. Any superficial vein can become varicose, but the veins most commonly affected are those in the legs, because standing and walking upright increases the pressure of the veins in your lower body. For many people, they're just a cosmetic concern. For other people, it can cause aching and discomfort, and sometimes they may lead to more serious problems. So self-care would include using the hose, the compression hose, exercise, elevating the legs, can help ease the pain of varicose veins and may prevent them from getting worse. But if you're concerned, or if they're concerned, they can check with the doctor and see if there's anything else that they can do. And of course, they need to elevate their legs when they can. Okay, let's do a case study. We have a 58-year-old African American client who is seeing his primary health care provider for an annual examination. His family his family history includes hypertension and type 2 diabetes. He is 30 pounds overweight and reports smoking a pack of cigarettes daily. He's a car salesman in a very competitive market. So what risk factors? We're going to discuss hypertension for this patient. Which risk factors does this client have? Well, we'll go to the next slide. We'll talk about it. He has a lot of risk factors, doesn't he? His age, he's African American, he has a positive family history for high blood pressure and diabetes. He smokes, he's overweight, and he has a job-related stress. He's a sitting duck. So, you as the nurse obtain these vital signs. His blood pressure is 142 over 90. Heart rate is 80. Respirations are 18. His temperature is 97.8. Based on these readings, does the client have hypertension? Well, he may. Let's think about this. Let's look at the next slide. So, his blood pressure indicates that he may have hypertension. However, the blood pressure should be checked in both arms, and 2 or more readings should be taken at each visit, with the average of the readings used as the value for the visit. You cannot base high blood pressure on one reading. So, based on his repeated readings, checking it at home, and looking at several readings and doing the average of those readings, we find out that he is diagnosed with hypertension. So, what teaching points will the nurse include when providing information about reducing the impact and successfully managing his hypertension? So, what are you going to do? Well, let's discuss that in our next slide. Yes, lifestyle changes, exercise, weight loss, alternative therapies are all very important to managing his blood pressure. So part of his care plan would include teaching him, that's your job, you teach him how to monitor his blood pressure. He should have a good, reliable blood pressure monitoring system at his home, not just when he comes to the clinic. He should stop smoking and decrease his caffeine intake. So, the primary health care provider prescribes hydrochlorothiazide, which we know is usually the first drug they give. So, he's getting 25 milligrams PO each morning. Which teaching will the nurse provide? Is this a loop diuretic that decreases sodium reabsorption? Should they eat foods rich in potassium, such as bananas and orange juice? Should they have a potassium supplement prescribed along with the drug? Should they have potassium? Or the drug is a potassium sparing diuretic that would help prevent the loss of essential potassium. Now, diuretics are a pretty major source of loss of potassium. So, what are you going to tell your patient? If they're taking a diuretic, and you have to know that it is a thiazide, and you've had your pharmacology, so you should know what thiazides do. So what is your answer? Okay, let's see. So we know that hydrochlorothiazide is a thiazide diuretic. The most frequent side effect is hypokalemia. So it's important to teach patients the signs of low potassium and which foods are rich in potassium. So the answer is B. This has been a very informative chapter, a very important chapter related to the cardiovascular system. It's not just the heart, it's all of the vascular system. So let's do a few questions here. I'm going to go over these questions with you because this is so important. Okay, I'm going to be concerned about the 53-year-old on diuretics with still an elevated blood pressure, 160 over 80. So this would be my priority patient to see first, to see what his pressure's doing and how he's feeling. The others I will see later. Their blood pressures are all within normal limits. Yep, that's the correct answer. This one may require intervention. The others are normal and you can see them later. So now you have a client with hypertension. They say, well, what's caused this? What's wrong? Well, pregnancy can cause essential hypertension. Is that correct? High cholesterol is a big factor in the development of essential hypertension. Stopping caffeine intake can cause hypertension to go away. Race is associated with secondary hypertension. What is your answer here? What do we know for sure? What do we know can cause essential hypertension? Remember when we were talking about essential hypertension? People can have a trait to have high blood pressure because they have high cholesterol. That is a causative agent of essential hypertension. The other statements are totally incorrect. So we have a patient that you're caring for that has many risk factors for hypertension. So when you're talking with them, which of the following symptoms is sometimes associated with hypertension as a symptom? Is it fainting, vomiting, headache, or speech slurring? Now this question is kind of, it's not tricky, but it's kind of, I don't know, I don't particularly like this question, but you should know that hypertension is often asymptomatic and it's a silent killer because they don't have any symptoms. Headaches may occur, but not always. Hypertension does not cause slurred speech, fainting, or vomiting.